Hi everyone, a blessed day to all. Praying that all of you are safe and doing well in your study. Our topic in this presentation is about monitoring and measuring the central venous pressure as well as changing the dressing and flushing the central lines or catheters. Before we proceed with our presentation, let us first have a brief review of the anatomy of the heart and the blood circulation. Our heart is a powerful muscle about the size of our fist. Every second, it pumps nutrients and oxygen-rich blood to our body. With each heartbeat, our heart sends blood through our circulatory system. Our heart has 4 chambers. The chambers are like rooms in the house of our heart. If we look at in this diagram of the heart, these chambers are divided into upper and the lower chambers, also into left chambers and the right chambers. The atria are your 2 upper heart chambers. You have the left atrium and the right atrium. On the other hand, we have the ventricles, which are the 2 lower heart chambers. We have the left ventricle and the right ventricle. Between the top and the bottom chambers, we have the heart valves. These are the heart valves. Your heart valves or our heart valves open and close to allow for proper blood flow. Your valves or our valves ensure that the blood flows only in one direction, otherwise there would be heart problems. These valves are the mitral, aortic, pulmonary, and the tricuspid valve. Your aortic valve connects our left ventricle and the aorta. The aorta is the large artery that carries the blood throughout your body. The mitral valve connects our left atrium and the left ventricle. The pulmonary valve connects our right ventricle and the pulmonary arteries. The pulmonary arteries are the arteries that carry blood to our lungs for oxygenation. The tricuspid valve connects our right atrium and the right ventricle. Now let us look at the blood flow or the blood circulation. So the blood comes from the body into the right atrium, passing through the superior vena cava. Okay, and then it enters the right ventricle via the tricuspid valves, and it moves and it is pushed into the pulmonary arteries, into the lungs for blood oxygenation. After picking up oxygen, the blood travels back to the heart through the pulmonary veins into the left ventricle, and it passes through the mitral valve, and it is pushed into the left ventricle and out to the body tissues through the aorta. It will now supply the oxygen and nutrients to our body. So, measurement of CVP is used to assess cardiac function, to monitor fluid therapy, and in particular to avoid overzealous fluid administration. As such, it can be used as one endpoint to fluid therapy. So now let us proceed to some definition of terms that are being used in this presentation. The first one is the central venous pressure, or known as CVP, which refers to the pressure within the right atrium or the great vein within the thorax. Let me remind you that the placement sites of central catheter includes the internal jugular vein, the femoral vein, and the subclavian vein. So as you can see in this picture. So the right internal jugular vein and the left subclavian vein are the most direct paths to the right atrium via the superior vena cava. The femoral vein are compressible sites and as such may be more appropriate for coagulopathic patients, while the subclavian vein approach is at the higher risk for pneumothorax than the internal jugular vein approach. So another term here is CVAD, which refers to the central venous access device, also known as central lines devices that is used to gain access to the central circulation. The central venous access device can be a short or long-term intravenous catheter inserted into centrally located vein with the tip residing in the lower third of the superior vena cava near each conjunction with the right atrium. So the following are the purposes for using central venous lines. The first one is to serve as a guide to fluid replacement, particularly in seriously ill patients. Also to estimate blood volume deficits and to determine pressure in the right atrium and central veins. Likewise, to evaluate for circulatory failure. Central venous lines also permits administration of medications and nutritional support that should not be given via a peripheral route or when the standard peripheral routes cannot be used. CVP lines are indicated for the patients with the following conditions such as congestive heart failure, decrease in myocardial contractility, renal failure, and tension pneumothorax because it allows us to monitor the central venous pressure. It is also indicated for the patients with pleural effusion, hypo or hypervolemia, decrease in myocardial contractility, and decreased cardiac output. So other indications include the following. For the patients with limited or difficult peripheral vascular access. For patients with prolonged intravenous IV therapy, because we know that CVP line can be used for long term. Those patients with frequent administration of blood or blood transfusion and blood products. And for patients with frequent blood sampling. So again, this is used if you need to measure the central venous pressure, so CVP line is the right choice. And for this patient with hemodialysis or hemofiltration, and patients for bone marrow and stem cell transplant. There are three most commonly used vein sites for catheter placements. These are the cephalic veins or the basilic veins. The second one is the subclavian vein and the internal and external jugular vein. So now let us have a closer look of the vein sites that is commonly used for catheter placement, such as your internal jugular vein, subclavian vein, the cephalic, the basilic vein, and the femoral vein. The subclavian access is preferable when the risk for infection is high, because the risk for infection increases with the duration of catheter use. The subclavian approach is probably the best choice if the patient is expected to require a catheter use for 5 days or more. When the risk for mechanical complication is unacceptable or when the subclavian catheter insertion fails, insertion should be attempted through the internal jugular vein or the femoral vein. and the catheter should be tunneled to reduce the risk for infection. When the expected duration of catheter use is less than 5 to 7 days, the risk for infection is limited, and the jugular approach is therefore preferable, given its lower associated risk for life-threatening mechanical complications. For patients with severe hypoxia or hemostasis disorders, the femoral approach is associated with an acceptable rate of complication, especially when the catheter is inserted under strict aseptic conditions. There are different types of central venous access device. These are the peripherally inserted central catheter or the PICC, the non-tunneled catheter or the CVC, the tunneled central venous catheter or known as Hickman, implant port or port A catheter. So, the peripherally inserted central catheter line gives your doctor access to the large central veins near the heart. It's generally used to give medications or liquid nutrition. A PICC line can help avoid the pain of frequent needle sticks and reduce the risk for irritation to the smaller veins in your arms. So, the advantages of using PICC lines includes the following. This can be used for long-term placement compared to 3 to 4 days with a peripheral IV access device. It can also be used to administer medications that may cause discomfort or burning in the peripheral IV site because this will not allow or cause pain or phlebitis. Blood draws can be performed through a PICC line. This will also reduce the risk of infiltration. Long-term patients can be provided medications and treatments from home easily with a PICC. These multiple lumens allow for multiple medications and treatment to run simultaneously into the body. So, another type of central venous access device is the non-tunneled central venous access device. So, as you can see in this image. So, there are advantages and disadvantages of using the non-tunneled central venous access device. For the advantages, it is easy to access. It reduces anxiety and the stress and trauma associated with treatment as less frequent venous access required. It is a safer route of administration for vesicant drugs and fluids that are unsuitable for peripheral cannula infusion. It also provides long-term venous access. On the other hand, the disadvantages includes the following. Permanent indwelling catheter can impact on activities and body image. There is a greater risk of infection. It requires care and maintenance, and it also requires port needle access. Another type of central venous access device is the tunneled central venous catheter, or known as Hickman. So these are the advantages and the disadvantages of using Hickman catheter. For the advantages, it has a large bore lumens. It is pain-free when accessed. It has single, double, or triple lumens for multiple infusions or for medication administration. The disadvantages includes high maintenance. It can alter body image. It requires theater for insertion and removal, and it increases risk of infection. So another type of CVAD is the implanted port or port A cath. So as you can see in this image. So this is another image of your implanted port or your port cath. As you can see in this picture, there is a port in the other parts of your port cath. So this picture is a non-coring needle and injection cup are used with the implanted port. Some needles may look different once inserted. So the advantages of using the implanted port or the port cath includes the following. It can remain in the vein for a long time. There is less discomfort since the IV therapy can be given more easily. No dressing or bandages are needed after the skin has healed when a needle is not in place. So another advantages of using the implanted port or the port cath is that it prevents the burning feeling, which is sometimes felt with medicine given by other IV methods. The activity is not restricted with the implanted port. If there is no needle in place, bathing, exercise, swimming, and playing are all possible once the incision has healed. So these are the principles of care that we must observe if our patient has central venous access device. It is important to confirm the placement of your device using chest X-ray, fluoroscopy, and breast blood return. So another principle of care includes aseptic and ant technique. So aseptic technique includes 5 moments of hand hygiene and ant or aseptic non-touch technique. So these are the 5 moments of hand hygiene. You must perform hand washing before touching a patient, before doing a procedure, after performing a procedure or body fluid exposure risk, after touching a patient, and lastly, after touching a patient's surroundings. So this image is just an example of the application of the principles of ant technique. So this is for wound, no? This can be also applied for your central venous access device. Okay, so this is just simply applying sterile technique, okay, by applying the principle of sterile to sterile and unsterile to unsterile. So these are the materials and supplies that are necessary for central venous access device insertion. We need the following, such as sterile gloves, as you can see in the picture, cleaning solutions, a special sponge, a special patch called biopatch, a clear barrier bandage such as Tegaderm or Covaderm. So for cleaning solution, we will need at least 2% chlorhexidine gluconate in 70% isopropyl alcohol, a povidone iodine in a 70% alcohol. Okay, so we will also need transparent dressing or TSM, gauze or non-woven fabric dressing. So this is just an image of our catheter. These are the lumens. You will also need at least 10 ml of syringe. So moving on to the principle of care for changing dressing. So it depends on the type of dressing. For the initial dressing, so the frequency of changing will be at least between 24 to 48 hours post-insertion. For transparent dressing, it can be changed every 7 days or as necessary if it is damp, loosened, or soiled. For the non-transparent dressing, it should be changed every 48 hours. For line changes, we must change IV lines every 3 days daily if the patient has TPN or total parenteral nutrition, and we should avoid disconnection and connection with lines. Do not reattach disconnected lines. So these are the different technique of flushing. We have pulsing technique, sash flushing technique, positive pressure technique, and heparin lock technique. It is important to know your materials and supplies, specifically the cup of your line, because this will help you determine which particular technique is needed. So remember that the main purpose of doing this flushing technique is to keep your line patent and to prevent formation of blood clots. So we usually flush our line before giving medication and after giving medication, and also in between infusion. However, it is important that you have to check your hospital protocols about this procedure of when is the best time to do the flushing and what are the requirements, because you may need to flush your line with 3 to 5 cc of normal saline, and again, this is based on your hospital policy. So you have to check your hospital protocol about the requirement. Pulsing technique is by performing push and then pulse and then flush technique. You can do this by adding 1 to 2 cc or ml of normal saline and then stop, and then push another 1 to 2 cc again. This just helps to give a turbulence and clear out this line. So again, check your hospital policy. So I will attach another video from YouTube on how to do these techniques. So sash flushing technique can be done by saline flush first to ensure patency of the line, and then clears the line of residual medication. And then you can administer medication or connection of the infusion. And after that, you can flush again your line with saline. Again, this is to ensure patency of the line and clears the line of residual medication. And then you can give heparin if the device requires heparin for patency. This is to minimize the potential of blood clot forming inside the catheter lumen. So, future nurses, you have to remember that in doing or performing any procedure to your patient, it is important to use your nursing process. And the very step of your nursing process is to do assessment. So for this particular procedure, it is important to assess the following. You have to assess the type of catheter that is being used. And you have to locate or check the location of the catheter tip. And then you have to check the type of infusion. And also check the agency policy regarding the central line care. To continue with your assessment, it is important to visually examine and carefully palpate insertion site daily for erythema or redness, drainage, tenderness, warmth, and edema. And routinely assess condition of the dressing and securement. It is also important to have a device catheter measurement for PICC line. and routinely assess for blood return and patency. So this is very important. For the nursing diagnosis, we have here an example of your nursing diagnosis. One is there is a risk for infection related to central line insertion, and risk for injury related to complications of central venous therapy. So this is just an example of your nursing diagnosis. Now let's proceed to the intervention. So it's now time for you to check your checklist. So now let us proceed to the procedure in your CVP, changing the dressing, flushing, and measurement. First, it is important to verify the doctor's order and the facility policy and procedure regarding the central venous pressure monitoring, changing of dressing, and flushing policy. Often, the procedure for CVAD flushing and dressing changes will be a standing order. Then you have to prepare materials or equipment needed. And then, of course, you have to perform hand washing and put on your PPE if necessary or if it is indicated. As mentioned in the previous slides, those are the materials or equipment needed. Okay, this is just another image of your materials that are necessary in the procedure or in this procedure. And then you can provide for client's privacy. Of course, this is for the comfort of your client. Then you can adjust the bed to comfortable working height for you to easily perform the procedure. And then assist the patient to a comfortable position that provides easy access to the CVAD insertion site and dressing. If the patient has a PICC, you have to position the patient with the arm extended from the body below the heart level, as you can see in this picture. And then you can use bath blanket to cover any exposed area other than the site. Your bath blanket is just a mini version of the usual blanket that we use. And then you can put on gloves and then assess CVAD insertion site for any inflammation, redness, and so forth. Through old dressing, you have to check over it, okay? And then you have to note the status of any sutures that may be present. Remove old dressing by lifting it distally and then working proximally. You have to make sure to stabilize the catheter, and then you can discard the dressing in trash receptacle. Now you can remove your gloves and discard because you were using the clean gloves. Then now it is the time for you to put on your sterile gloves. You have to remember the techniques of wearing gloves. So in this image, you can see that of course you have to do hand washing. And this is the proper way of removing your gloves. And this is the proper way of opening your surgical gloves. So as you can see in this image, number 4 image, so you can see your surgical gloves in this position. There is a cuff, okay? So you have to use your technique in wearing sterile gloves, the sterile to sterile technique or the unsterile to unsterile technique. So we have here, you can start with the skin to skin technique. Okay, so that's why you are only touching the cuff part because you have your bare hands, no gloves yet. So this part, the colored one, is the sterile part. Okay, so now you wear first. Okay, using your dominant hand, you insert your non-dominant hand. Okay, and then as you can see, you are only holding the cuff of your surgical gloves. And then you can now pick the second gloves. Okay, so you can now use your, for example, this is the right hand because this is the left glove. This time your gloved hand must be touching the sterile part. So this technique is known as glove to glove technique. Okay, skin to skin, and this time is glove to glove technique. You are only holding the inside part. As you can see in number 7, you have to avoid this colored part touching your skin. You can insert your ungloved hand here, and then while your gloved hand still handling the cuff, no, the sterile part of the cuff. This part, the uncolored part, will touch the skin of the client. So you have to be very careful. This picture, as you can see in this picture, actually in real setting, this is not, this one, the thumb should not touch the skin. You are only touching the sterile part of the gloves, because if your thumb will touch your skin, you will now be unsterile. So you have to be careful that your thumb or your other fingers should not touch the skin of your client. So remember to use your skin to skin, okay, skin to skin pre-procedure, and then glove to glove technique. So now you can wipe off any old blood or drainage with a sterile antimicrobial wipe, starting at insertion site and continuing in a circle motion. Using the chlorhexidine swab, cleanse the site. Cleanse directly over the insertion site by pressing applicator against the skin, as you can see in the picture. So this is the catheter, and this is how you will clean the old blood using your special sponge. Okay, in a circle motion, okay, over the insertion site. All right. Apply chlorhexidine using back and forth friction rub for at least 30 seconds. As you can see, back and forth, moving outward from the site using a scrubbing motion to continue to clean. So moving outward, for example, this is the site, so you are sponging back and forth, moving outward, covering at least 2 to 3 inches. So this is the site. Okay, this is the insertion site. For example, this is the insertion site. So you are moving. So itong example na to, this is the catheter is not here because I'm just showing you an example of an insertion site. Example. Okay, do not wipe or blot. Okay, allow to dry completely. Apply the skin protectant to the same area, avoiding direct application to insertion site and allow to dry to dito lang sa sides. Stabilize catheter hub by holding it in place with your non-dominant hand. Okay, this is your non-dominant hand. Use an alcohol wipe. Okay, you can improvise. You can improvise your sponge or a special sponge or alcohol wipe to clean each lumen of the catheter. So yung catheter natin may mga lumens yan. Starting at the insertion site and move outward. Okay? Apply transparent dressing or securement stabilization device centering over the insertion site. If the patient has PICC in place, measure the length of the catheter that extends out the insertion site. Importante natin i-measure yon kung gaano kahaba ang kailangan mo. Working with one lumen at a time, you have to remove the end cup and then cleanse the end of the lumen with an alcohol swab, and then you can apply new end cup. Repeat for each lumen, and secure catheter lumens and or tubing that extend outside the dressing with tape. If required, you can flush each lumen of the CVAD. The amount of saline and heparin flushes varies depending on the specific CVAD and policy or hospital's policy. So now you can cleanse and cup with an antimicrobial swab. So as you can see in the picture, for at least 20 seconds. Then insert the saline flush syringe into the cup of the extension tubing. Pull back on the syringe to aspirate the catheter for positive blood return. If positive, you can now instill the solution over 1 minute or flush the line according to hospital policy. Now remove the syringe and insert heparin syringe and instill the volume solution designated by facility policy over 1 minute or again according to facility policy. Now you can remove the syringe and re-clamp the lumen and then remove your gloves. Label the dressing with date, time of change, and initials. And then you can resume fluid infusion if indicated. Check that IV flow is accurate and the system is patent. And then for a specific procedure, I also have here a link for YouTube so you can watch how to perform the procedure. So now let us proceed to CVP measurement or central venous pressure measurement. Now you can place the client in supine position. If indicated, you can adjust the position. So as you can see in this picture, you can at least place 1 pillow. Okay, and then place the manometer at the 0 level adjacent to the PICC intercostal space mid-axillary line. And then move the manometer scale up and down to allow the bubble to align with 0 on the scale. This is referred to as zeroing the manometer. Then you can now open the CVP and IV port and closes the patient port. So this is the line going to the patient. So you can turn the 3-way tap off to the patient and you are now opening the manometer. So nakabukas yung manometer as well as the CVP. And this line is going to the patient. So dapat ito ay close. Now allow IV solutions to flow to the CVP line to about 20 to 25 centimeter level of the manometer. Now you can close the IV line and you can open the CVP line and the patient's line. Okay. So yung IV line natin, this is the lines that is connected to the bottle or the IV bottle. Now you can instruct the patients to take a deep breath and observe for fluid fluctuation. In case the patient is intubated and conscious, you can detach patient from the ventilator temporarily and ask the patient to take a deep breath. If the patient is intubated and unable to follow commands, you can just observe the fluid fluctuation at the end of inspiration. Note the level where the fluctuation stabilizes. Make sure no air has entered the IV line during the reading. Closes the CVP line and opens the IV line to allow flow to the patient's line for flushing. So this image show a summary of the procedures. As you can see, the patient is on supine position. The manometer is at 0 point. So this is the IV line. So this is the three-way stop lock. No, meron kang tiniturn na ito, katulad niyan. So this is the IV line. This is the manometer, and this line is going to the patient. Okay. So if you place the stopcock here, this is closed, no? And then if you turn it here, so the manometer is to the patient. And kapag nandito, IV solution to manometer, papasok dito yung IV solution. And here, kinu-close mo na, so IV solution can now flow to the patient, diba? As you can see in this picture. Now you can reattach this ventilator if the patient is on ventilator, and then you can reposition the patient. Now it is important to regulate IV fluid as previously ordered. Cleanse and returns use equipment, remove PPE if used, and then washes your hands. Document the CVP reading, the condition or the skin condition of the client, and the position of client when you do the CVP reading. So this is just another link for another YouTube reference. So this link is also attached in your G classroom. Now, after doing the procedure, of course, it is important to document your procedure. So, include in your documentation the amount, the type, and the frequency of flash solution, the type of dressing and the tubing changes, and your assessment of the sites. Before ending this presentation, let me share to you this quote by Maya Angelou. As a nurse, we have the opportunity to heal the mind, soul, heart, and body of our patient, their families, and ourselves. They may forget your name, but they will never forget how you made them feel. Thank you, everyone. Hope you learned a lot in this presentation. God bless!